My topic is gastroprotection in dual antiplatelet therapy, a work in progress audit of outpatient cardiac prescription. So, as you know, the per minutes coronary intervention, or as known as PCI, is a widely used procedure to treat coronary diseases, which are a major causes of heart attack or any other cardiac complications. So most patients on PCI are given stent. So due to that, the risk of stent thrombosis increases. So for that, we have a dual antiplatelet therapy, which combines aspirin with P2Y12 inhibitor, such as clopidogrel um, or TI. So as these two are combined to give a dual antiplatelet therapy. Although this is an effective procedure, there are increased risk of gastrointestinal bleeding, since like aspirin, gastric mucosa, or an P2Y12 inhibitor impairs platelet aggregation. So due to this, the risk of gastrointestinal bleeding increases. For these organizations like European Society of Cardiology or Medical Association have made a guidelines for which says proton pump inhibitor to protect the gastrointestinal bleeding as well. But the question is, in the real time practices with limited environment, low income resources, is this being that brings us to the So our objective of this audit was to assess whether the DAPT is being given in the post-PCI patients and whether the recommended guidelines are being followed or not. So this is an ongoing prospective study, and these results are just an initial findings for the first 10 prescriptions that we have, first 100 prescriptions that we have collected so far. And this is conducted in a tertiary care center in North India, tertiary care hospital. And what we did is review the prescriptions of outpatient prescriptions for DAPT and as well as gastroprotection. So as for the results, as you can see in the bar chart, out of 100 prescriptions prescribed, there were 96% which adhered to these guidelines, which means that both aspirin as well as proton pump inhibitors were prescribed, whereas 31% did not adhere, and mostly 20, with the notable 25% you can see is that P2Y12 inhibitor was the missing component. Now, narrowing down to the gastroprotection, if we see in like those 96 prescriptions, out of those, if we see in at least 48 prescriptions, there were gastroprotection present. That means that rounds out to about like 96.6%. But other there were 18 prescriptions that did not adhere, that did not have gastroprotection, which increases the chances of gastrointestinal bleeding in the patient. So, and there were three prescriptions that had improper documentation. So that this, as we see the result, we have two major concerns here. Firstly, that the DAPT is itself not being properly prescribed, with a significant amount of 31% of prescriptions not having proper DAPT therapy, which increases the chances of secondary cardiac output complications in patients. And the second is that even though DAPT is being prescribed, there is 1 in every 4 prescriptions which do not have gastroprotection, which is increasing the GI bleeding. So what this points out is like the significance of this result is it shows a gap between evidence-based guidelines and the real-time practices that is being followed. And for so what can be the measures that can be taken? It is like there could be low cost prescribing methods taken, measures taken, or educational sessions that can be taken, or even a simple checklist prompt that can be present at least when the patient is going out of the OPD, that could check whether the guidelines are being followed or not. So although this project is being conducted, but it also had some limitations with it. The limitations were like the data is being collected from a written prescription. So we couldn't assess the clinical reasoning why the decision was taken, whether to prescribe aspirin or just aspirin or both. Or we couldn't take in account other factors like whether the patient had any previous history of gastrointestinal bleeding or not, or whether the patient had H. pylori in status about H. pylori or not. And there were few prescriptions which had improper or incomplete data, which also limited us for the data interpretation. So now that I would like to conclude is by saying, as we proceed, the project proceeds, what I am expecting is that the final result would strengthen my initial observation, and it will further support the need to implement a guidance, clinical based guidance, and a safe practice that can be incorporated in a day-to-day life when the patient load is high or something, in a very simple and practical intervention. So thank you.
Yeah, nice presentation. You're investigating something that's very important. We have time for one question. Is there something in the chat?
There is not. Do you have any?
Well, good. Well, proceed. I think this is an interesting topic that you're going into, but I realize the fact it's a difficult area and it's going to require a lot of work. But good luck.
Please support our mission to improve quality of patient care through education. Join us, follow us, and share this content with family and friends.